Hi everyone, thanks for listening to my presentation. Today I'll be talking about hydroxychloroquine. Hydroxychloroquine. Okay, sit back, let's go. Based on the current ongoing controversy as per the use of hydroxychloroquine in the face of COVID-19 pandemic, I need to state the following. That don't prevent people from knowing the truth. I am not ready to mislead anyone. The info here is based on the available facts as of today. I'm truly wishing everyone affected with COVID-19 a quick relief and a speedy recovery. On the use of hydroxychloroquine to treat COVID-19, I can say that currently the medication is undergoing investigation as of today. The safety and efficacy not yet established. The use of hydroxychloroquine is off-label, and we have limited data to lay our hands upon. It is now supported for prophylaxis in COVID-19, and studies are ongoing as I speak. Going through the medical literature about the use of hydroxychloroquine and COVID-19, the facts are we still have controversy. Controversy is still on because the use of hydroxychloroquine is still under investigation by many medical jurisdictions globally. Initially mentioned to have been tested in animals, but not in humans. Some other drugs are still under investigation as well, and that is when it comes to COVID-19. The story may, however, change for global usage or not. Well, we'll still be watching for that today, tomorrow, or days to come. We'll be watching out for that. So, generally, hydroxychloroquine could have brand names like Plaquenil, Apple hydroxyquinine, Jump hydroxychloroquine sulfate, hydroxychloroquine DSC, and Pro hydroxychloroquine 200, depending on your jurisdiction. Uses of aminoquinoline. They are known as 4-aminoquinoline. Useful in malaria treatment, dermatomyositis, lupus erythematosus, porphyria cutanea tatum, Sjögren's syndrome, and Q fever, Coxiella bonnetii. Also useful in treating rheumatoid arthritis, sarcoidosis, in malaria prophylaxis for those who are traveling from non-malaria part of the world to the malaria endemic part of the world, juvenile rheumatoid arthritis, and is not useful in chloroquine-resistant malaria. It could appear in various forms like tablets, 200 mg per tablet, or suspension at 25 mg per ml or 50 mg per ml. Dose. The dose is variable. It depends on the exact disease you are about to treat and the weight of the patient, also the severity of the illness you are about to tackle, and whether you are using it for prophylaxis or treatment, for example, in malaria. Still on dose, it could be given daily or on alternate days. Sometimes you could have skipping doses in certain days, and hydroxychloroquine sulfate 200 mg is equivalent to hydroxychloroquine base 155 mg. Note this, to avoid retinopathy and permanent blindness, please do not go beyond the recommended maximum daily dose. Let me repeat, to avoid retinopathy and permanent blindness, do not go beyond the recommended maximum daily dose. Dosing examples. For malaria prophylaxis of Plasmodium falciparum, vivus or malariae, for travelers from non-endemic to endemic regions of the world, the prescription can include 400 mg once daily on the same day each week. For example, you may choose every Sunday, and you start 1 to 2 weeks before you embark on the trip. While on ground at your destination, you continue taking the 400 mg every Sunday, if you choose Sunday anyway, throughout your stay. You will stop only after you have returned to your country, and you will continue after return for 4 weeks. But for malaria treatment, it is a bit different. You will likely be given 800 mg start, 400 mg 6 hours later, 400 mg at 24 hours, and 400 mg at 48 hours. But remember, I've said initially, this will be variable. It depends on the weight, the age, the level of the illness, and what exactly you're tackling. Still on dosing. If you're handling porphyria cutaneous tarda with hydroxychloroquine, you can use 100 mg twice weekly. You're going to continue until the urine and plasma porphyrin are within the normal range. And you're not just going to stop immediately. You will let that be for a while. Might be between 1, 2, 3 to 6 months. For Sjögren's syndrome, you take 200 mg daily. For rheumatoid arthritis, you take 200 mg daily or 400 mg in 2 divided doses. Please never exceed anything greater than 5 mg per kilogram per day. Remember, to prevent retinopathy and irreversible blindness, please don't do that. For lupus erythematosus, 200 mg start or 400 mg in 2 divided doses. Adverse reactions. Okay, this is where we need to sit down together and reason together. Nausea, vomiting, and diarrhea. Pruritus, or some will know it to be itching, is very common with a lot of people on this medication. Retinopathy and blindness. Cardiomyopathy leading to heart failure. Arrhythmia because of prolonged QT interval leading to torsade point, and torsade point will progress to ventricular tachycardia, and from ventricular tachycardia to ventricular fibrillation. From ventricular fibrillation, if there's no emergency cardioversion, can lead to asystole. The asystole will lead to possible death. And of course, there's likelihood of hypoglycemia that could be life-threatening. Still on adverse reactions. The respiratory system is not spared because we could have bronchospasm, myopathy, ataxia, dizziness, hearing loss, particularly sensorineural hearing loss, psychosis, and suicidal tendencies, seizures, vertigo, and nightmares. Also possible could be hypersensitivity leading to angioedema, Stevens-Johnson syndrome, or toxic epidermal necrolysis. Each of these could kill. Acute hepatic failure, agranulocytosis, anemia, and pancytopenia when the bone marrow is suppressed. Hemolysis is possible with G6PD deficiency, and of course, abdominal pain. There are some contraindications. In other words, we don't give this medication to anyone with the following: hypersensitivity to hydroxychloroquine. Please, no. pre-existing retinopathy. Why? Because chloroquine on its own could give retinopathy and irreversible blindness. Children less than 6 years old and individuals that are lightweight and anything less than 35 kilograms, no hydroxychloroquine. Warnings. I don't give warning, but for the safety of the patients, we need to warn ourselves. Cardiomyopathy can result in heart failure and death. We all doctors know that cardiomyopathy, not only heart failure, could even lead to arrhythmia on its own. And hydroxychloroquine may exacerbate underlying myocardial dysfunction. In other words, with prolonged QT leading to torsade de pointes, ventricular tachycardia, ventricular fibrillation, asystole, and death, hydroxychloroquine hits the heart. Probability of a severe anaphylaxis, giving us angioedema, Stevens-Johnson syndrome, toxic epidermal necrolysis is also there that could lead to death. Possibility of bone marrow depression leading to pancytopenia, anemia, and agranulocytosis is another problem. Life-threatening hypoglycemia, because it's called life-threatening, right? And when the brain is not supplied with glucose within some few minutes, we are in for big trouble. Neuromyopathy leading to progressive weakness, and of course suicidal possibility. We need to know that all these are possible. Still on warnings, retinal toxicity will lead to irreversible retinopathy. The situation is worse in individuals with G6PD deficiency, and it can worsen psoriasis. It is bad for renal failure, therefore we must reduce the dosage in the face of renal impairment. It is not effective when it is in an endemic region with chloroquine-resistant malaria. Drug-drug interaction. Well, you might have to ask your pharmacist because there are a lot of them, but I'll just mention two here. If you use this medication with digoxin, you are going to increase the serum level of digoxin, and you know what that means. If you use this medication with haloperidol, you are going to increase the possibility or probability of prolonged QT. And when we are dealing with prolonged QT, I will not be lazy not to mention that from prolonged QT, it will go to torsade de pointes. And if torsade de pointes is not corrected, it will lead to ventricular tachycardia. If no management, it will lead to ventricular fibrillation. If it's not corrected with cardioversion, then we're going into asystole. And of course, at that level, we are close to the grave, death. In conclusion, I will end this presentation the way I started. Don't prevent people from knowing the truth, please. I'm not ready to mislead anyone. The info here is based on the available facts as of today, April 2020. Wishing everyone affected a quick relief and speedy recovery. Your doctor will let you know if this medication has been approved for COVID-19 or not. And I'm making the promise right now that I will also make a new presentation once that has become globally acceptable. I have decided to keep myself away from the controversy about what I've seen online right now, that FDA has approved this medication or not, for use in US or not. I don't want to go into that. But when it becomes acceptable generally and available for medical practitioners, I will make another presentation. But all eyes are on new changes. Once that is done, I will make another presentation. Thanks for listening. Kindly subscribe to my channel so that the promised presentation or presentations could be received by you immediately they are published. I appreciate it.